All right, good morning, everyone. My name is Laura Reed, and I am the Behavioral Health Senior Program Advisor in the Behavioral Health Division at DMAS. And welcome to our updated telehealth training. I'm looking in the chat, and there are people having a hard time hearing. That's on your all's end, so you'll need to figure that out. Most people can hear us, so hopefully you can troubleshoot. We are recording this training this morning, and the recording and the PowerPoint will be posted to our website in the next week. No need to take notes or anything. Just listen as we go. Yeah, so thanks for being here this morning. A couple of logistics today. I talked about it's going to be recorded and posted to our website. All of you all are muted and can't come off mute. And during the presentation, we're not going to be taking any questions during the presentation. However, if you want to, you are able to use the Q&A function to put in any questions you may have along the way. And if we have time at the end, I'll choose the ones that are most prominent for us to answer. Please use the Q&A function and not the chat function. The chat function, there are currently 378 individuals on the call. The chat function is too hard for us to monitor and figure out, who said what and when. The Q&A function is much more functional for us. So please use that. And when you're putting in your question, if you could also put in your full name and your contact information, so we can also keep track of that. Please know that if we don't get to your question, you're more than welcome to email us at our divisional email, which we will give you at the end of our presentation. And also, we will be taking all of the questions that you all submit into the Q&A function and be developing an FAQ over the next couple of weeks that we will also post to our website. So those questions are certainly important to us. So we want to make sure that we give you clear direction and resources for those questions. So those are the logisticals for this morning. I'm going to remind you of these logistics as we go through the presentation. We are currently at 402 individuals, so that's awesome. I'm excited. All right, so I'm going to hand it over to my right and left hand, my colleague Sue Klaus, who is our Senior Mental Health Policy Specialist here at DMAS in our Behavioral Health Division. And she is the expert on all things telehealth related. So she's going to be doing the presentation this morning. And I hope you all enjoy. And thank you so much for being here. Sue?
Good morning. We're going to start by going through our agenda. We're going to start with an update on the federal COVID-19 public health emergency and related flexibility. We're going to start by giving you an update. Then we're going to go through a brief overview of the telehealth services supplement. And then finally, we're going to go through our planned future updates to the telehealth services supplement. And I typically refer to the telehealth services supplement as just the telehealth supplement, so I might do so throughout this presentation today, but just know that they're the same thing. And then at the very end, we'll have a question and answer session. First of all, where can you find the telehealth services supplement? It's located along with our provider manuals. So if you go to this link for our provider manual library, you can find the telehealth services supplement in with the arts supplement, in the arts manual, the mental health services manual, the psychiatric services, and the physician and practitioner manuals. So you can find the telehealth supplement when you go into any of those manuals. And on the next slide, this just shows you what it looks like when you click on the mental health services manual. you'll see the telehealth services supplement is way down there at the bottom, and it's referred to there as Chapter 16, but it's really just a supplement. And just a note that providers are responsible for adhering to everything that's in the telehealth services supplement. So it's a really important document to go and locate and read. Before we get started by giving you an overview of that supplement, we just want to go through some definitions. The first definition is telehealth, and I'll just read it. This comes right from the telehealth supplement. Telehealth means the use of telecommunications and information technology to provide access to medical and behavioral health assessment, diagnosis, intervention, consultation, supervision, and information across distance. Telehealth encompasses telemedicine, as well as a broader umbrella of services that includes the use of such technologies as telephones, interactive and secure medical tablets, remote patient monitoring devices, and store and forward devices. So telehealth includes telemedicine, plus other modalities of providing services across technology. And you can see ones on there like the remote patient monitoring and store and forward. We're not going to talk about those at all today, but if you want to find out more information on them, you can look in the telehealth supplement. And on the next slide is our definition of telemedicine. And this also comes right from the telehealth supplement. Telemedicine is a means of providing services through the use of two-way, real-time, interactive electronic communication between the member and the provider located at a site distant from the member. This electronic communication must include, at a minimum, the use of audio and video equipment. So this is really important to note, is that telemedicine does not include an audio-only telephone. So when we talk about audio-only telehealth later in this presentation, telemedicine does not include audio-only telehealth. So those are two different things. And we'll probably remind you throughout the training that telemedicine must include both the audio and the visual components. Next slide. We are trying to be consistent with these terms across our behavioral health manuals. So if there is an in-person requirement, the in-person requirement can only be met by being in the physical presence of the individual, and it can't be met through telemedicine. So unless it's otherwise noted, though, if our manual says face-to-face, but there's no notation that it has to be through in person, then you can meet your face-to-face requirements through either meeting in person with the individual or through telemedicine, which once again, the telemedicine must include audio and visual components. And I just wanted to note a few things just so you're not confused, because the definition of the comprehensive needs assessment does include the phrase face-to-face, but some of our services require an in-person comprehensive needs assessment. And you would find that information by looking within the service itself. And I think in the future, we should probably update that definition of comprehensive needs assessment just so there's no confusion. But we just wanted to point out that some services do require an in-person comprehensive needs assessment. And then when we were working on this training, I discovered that some of the waiver services, their definition of face-to-face requires in person. So if you're also a waiver provider, just make sure that you're looking at the definitions for waiver services. So but in the behavioral health world, we're trying to be really consistent with these terms, but we can't guarantee what you're going to find in other programs. Next slide. This is the briefest overview I think you'll find of the federal COVID-19 public health emergency. It was declared on March 13th, 2020. And what the federal public health emergency allowed us to do was to quickly update our policies to allow for continued service coverage. So it gave us the authority to do things that we previously didn't have the authority to do. But the federal COVID-19 public health emergency ends at the end of the day on May 11th, 2023. Next slide, please. This is the link for the DMAS website where you can find all of our COVID-19 related information. You can find the recent bulletins related to the end of the public health emergency, including return to normal enrollment. And you can also find the history of the flexibilities related to the public health emergency. So this is where you can find the full history of the flexibilities. Many flexibilities have already expired. Some of them were only allowed temporarily, and some of them were allowed temporarily under state public health emergencies. So it's complicated to follow. So if you go to this website and you look through, there's a lot of charts that will tell you like when some of these flexibilities expire. If you look through and you still have questions, please feel free to email us. Today, we're just going to focus on the behavioral health flexibilities that are currently allowed, but will expire on May 11th. So, next slide. Some of the flexibilities have already been made permanent. In the arts program, opioid treatment programs may administer medication as take-home dosages for up to a 28-day supply. A member's home is allowed to serve as the originating site for a prescription of buprenorphine. Electronic signatures are now permitted as described in Chapter 2 of the Medicaid manuals. 90-day supplies are allowed for many medications. Co-payments were eliminated for Medicaid and FAMAS members. And many behavioral health services may now be provided through telemedicine in accordance with the Telehealth Services Supplement. And we're going to go through those services on later slides, so we won't talk about them here. Next slide. We would really encourage providers to look at the document that it's located on the COVID-19 webpage on the DMAS website. It's entitled COVID-19 Public Health Emergency Flexibilities, and it was updated on April 3rd, 2023. And here you can find the full list of flexibilities that were still allowed. And then it'll give you an update on what's happening with those flexibilities as of May 11th. And it goes through some of the waiver services are on there, and there are also some policies that affected all Medicaid providers. So we'd encourage you to go and look at that document. We're just going to go through now and go through the behavioral health flexibilities that are expiring. So during the public health emergency, providers of therapeutic day treatment, intensive in-home, mental health skill building, and psychosocial rehab were allowed to provide 1 unit of service through audio-only telehealth per day. And that flexibility won't be continued after May 11th. Just a note, and we'll go through them, is that many of those services are allowed through telemedicine, but they will no longer be allowed through audio-only services. Next slide. During the public health emergency, providers of therapeutic day treatment, intensive in-home, mental health skill building, and psychosocial rehab were allowed to bill for the first unit of service, even if the time spent did not meet the time requirement to bill a service unit. And that flexibility will not be continued after May 11th, 2023. Next slide. During the public health emergency, providers of applied behavior analysis were allowed to provide family adaptive behavior treatment. Those codes were 97156 and 97157. They were allowed through audio-only telehealth, and that flexibility will not be continued after May 11th. You can note here too that they will be allowed through telemedicine, just not through audio-only telehealth. Next slide. During the public health emergency, providers of applied behavior analysis, we're allowed to conduct initial assessments through telemedicine. That flexibility will not be continued after May 11th. So after May 11th, initial assessments for ABA will all have to be conducted in person. Next slide. During the public health emergency, independent assessment, certification, and coordination team assessments, these are our IACT assessments for children or for youth in PRTFs and TGHs. They were allowed to occur through audio-only telehealth, and this flexibility will not be continued after May 11th, but that they can continue through telemedicine. Next slide. During the public health emergency, outpatient psychiatric service face-to-face requirements were waived. And this is one flexibility where several outpatient CPT codes will be permitted through audio-only telehealth after May 11th. The remaining CPT codes will be required face-to-face. Once again, that face-to-face can be in person or through telemedicine. And we're going to give you a lot more information on those codes on later slides. This is a snapshot of our telehealth policy evolution. Prior to the public health emergency, our telemedicine policy was based on a 2014 memo. So that's what our agency started with during the shutdown. Prior to the public health emergency, originating sites were very limited. But during PHE, and just so you know, the originating site is where the member is during the telehealth or during telemedicine. The originating site allowance has been expanded to include any location of the member at the time the service is rendered. So examples of originating sites, and I got this from the telehealth supplement, include medical care facilities, a provider outpatient office, the member residence or school, or other community location. So basically it can occur in almost any individual where the member is located. Prior to the PHE, in regards to telemedicine, it was based on that 2014 policy. Then during the public health emergency, telemedicine was covered as described in Medicaid memos and in the telehealth services supplement. But then now that the PHE is expiring, going forward, telemedicine can only be provided as described in the telehealth services supplement. Prior to the PHE, when providers were billing telemedicine, they had to use the GT modifier. During the initial stages of the public health emergency, it was encouraged that providers use that modifier, but it wasn't required. And as of July 1st, 2021, the GT modifier is required when providing services through telemedicine, as described in the telehealth services supplement. And then prior to the public health emergency, audio-only telehealth wasn't a thing. It wasn't allowed. During the PHE, it's been allowed for some services, and some services it was allowed initially, but that flexibility expired a while ago. Some of these flexibilities expired on July 1st of 2021. And then after the PHE, the audio-only telehealth policy is still in policy development. We're going to go through a list of the known allowed outpatient CPT codes on a later slide, and audio-only telehealth policy will be added to the telehealth services supplement at a later date, and also a modifier will be required at a future date. But right now, that's still all in policy development. Next slide. This is an overview of what you can find in the telehealth services supplement. You can find more definitions related to telehealth than we went over at the beginning of the presentation. You can find lists of reimbursable telehealth services, not just the behavioral health ones that we're going to go through. You can find conditions that must be met for a telehealth service to be eligible for reimbursement. And then there are additional conditions that must be met depending on the telehealth modality. We're going to go through the telemedicine ones in a little bit, but the telehealth supplement goes through the different modalities and what's required to bill them. There's telehealth billing guidance. There's provider and documentation requirements, and there's information on member choice and education. And once again, the telehealth supplement is a supplement to the arts and the mental health services and the psych manual and the physician practitioner manual. Next slide. The next few slides, this is information that comes from a general telehealth training, and it was created by the DMAS Office of the Chief Medical Officer, which has oversight of the telehealth policy. So the Behavioral Health Division provides input, but we don't have oversight of the telehealth policy. At the end of the training, we're going to give you a general email box that you can email your general telehealth policy questions to. Your behavioral health telehealth questions you can send to the enhanced BH box. But if you have just a general telehealth policy question, there is a different email address you can send those to. So these are universal telehealth policies across all services for Medicaid reimbursement. The service must be clinically appropriate to be delivered by a telehealth. The service must meet all the same code requirements as if you were providing it in person. The service must meet state and federal laws regarding confidentiality of information and patients' right to medical information. The services must meet applicable state laws, regulations, and licensure requirements on telehealth. And the service limitations are the same as in person unless otherwise noted. So in the telehealth supplement, you'll see in the tables in the back, there's a column for limitations, and you'll see some limitations listed there by service. So it's important to go through those and see if there are any limits when you provide the service through telemedicine or telehealth. Next slide. These are some of the telemedicine specific conditions. Telemedicine must be provided with the same standard of care as an in-person service. Telemedicine must not be used when in-person services are clinically necessary. The provider is the one for determining whether it's appropriate or not. Telemedicine must be able to be converted to in-person if needed. Next slide. These are billing procedures for telemedicine. Provider types are authorized to bill telemedicine for services are the same as those provider types allowed to bill for in-person services. So there's no different provider types that can provide telemedicine. It's all the same provider types. The modifiers is used as GT, which is unchanged from prior to the PHE. The place of service is where the service would have normally been provided. I think this has been a really common question because providers want to use the place where the member is. But the place of service is where the service would normally have been provided if it was provided in person. Providers can bill an originating site facility fee. But in order to bill it, it has to be medically necessary for a provider to be physically present with the member at the originating site at the time the telemedicine service is delivered. And the originating site has to be a provider location where healthcare services are rendered, and it doesn't include the member's residence. So this originating site fee is typically billed when providers have two different locations and the member is at one location, and the provider providing the service is at a different location, but the member requires somebody to be present with them. So in those instances, providers can bill this originating site facility fee, and there's more information about that in the telehealth supplement. Next slide. These are additional telemedicine requirements. Providers must maintain a practice located in Virginia or be able to make a referral to a Virginia-based provider. Providers must meet state licensure, registration, or certification requirements for the applicable health regulatory board with the Virginia Department of Health Professions. And we would also encourage you to keep up with the health regulatory boards because they're all looking at expanding some of the out-of-state licensure allowances, and DMAS would follow whatever the Department of Health Professions decides. So it's something to keep up with them. Informed patient consent must be documented in the medical record. And there is a list in the telehealth supplement that goes through all the required information for patient consent. Equipment must be of sufficient audio-visual quality to be functionally equivalent to in-person. And the documentation requirements are the same as for a comparable in-person service. Next slide. So when you go into the telehealth services supplement, Table 2 lists the behavioral health services that are allowed through telemedicine. So we're just going to briefly go through them. We would encourage you to look at Table 2 for the actual list of the actual codes. We didn't include the codes on these slides. The services allowed are early intervention, screening, brief intervention, and referral to treatment. I believe this is also called SBIRT. It's ACM 0.5. Case management, substance use, mental health, and treatment foster care are all allowed through telemedicine. Peer recovery support services, opioid treatment programs, and office-based addiction treatment, which includes substance use case care coordination. Outpatient psychiatric and outpatient substance use services are allowed, and the list of CPT codes is included in Table 2. So it's limited to those CPT codes that are included in Table 2. Next slide. Additional services that are allowed through telemedicine include intensive in-home, therapeutic day treatment, psychosocial rehab, mental health skill building services, multisystemic therapy, functional family therapy, applied behavior analysis, which also has limited CPT codes. And we tried to indicate on here which services require the initial assessment to be in person, just so there isn't any confusion. Slide. Additional behavioral health services allowed through telemedicine include assertive community treatment, a mental health and substance use intensive outpatient, mental health and substance use partial hospitalization, mobile crisis response with limits, and those limits are included, I believe, both in the telehealth supplement and in Appendix G. We're trying to update it to make it consistent, but I believe we just referred to Appendix G in the telehealth supplement. Some professional services in 23-hour crisis stabilization and residential crisis stabilization units can also be provided through telemedicine. And you can find that information in Appendix G to the Mental Health Services Manual. Next slide. For children in Children's Residential Treatment Services, these are our TGHs and PRTFs. The IACT initial assessment and the follow-up assessment can be provided through telemedicine. And then within both Children's Residential and Arts Residential Services, professional services as allowed through the applicable CPT code. So these are your licensed professionals providing services in those settings. If the CPT code is allowed through telemedicine, then it's allowed through telemedicine in the residential setting. Next slide. So the rest of our slides.
I'm gonna interrupt you and just remind the attendees. If you have questions, please put them in the Q&A function and not the chat, so we can keep track of them. When you put in a question, please put your full name and your contact information, as we will be collecting these to develop an FAQ resource. Thank you.
Thank you, Laura. So for the rest of the slides, we're going to go through changes that we plan to make to the telehealth supplement. So these are changes that we know need to be made, but they haven't yet been made. So you can save this training and just know that these will eventually be effective, the dates on the slides. So there were some CPT codes that were updated effective January 1st, and we haven't been able to update the telehealth supplement yet with them, but they're allowed through telemedicine as of January 1st. CPT codes for multifamily therapy 96202 and 96203 will be added to Table 2, so it'll be allowed through telemedicine. And the CPT codes for prolonged services 99354 through 99357 will be replaced with the updated codes for this service 99417 and 99418. So until we can get that updated, you can provide those services through telemedicine and just bill them under the new codes, which were effective January 1st. Next slide. These are just some corrections we plan to make to Table 2. We forgot to include psychosocial rehab. The assessment for psychosocial rehab was allowed through telemedicine prior to the PHE. It's been allowed to be billed with the GT modifier, and we plan to continue that. We just forgot to put it on Table 2, so we'll be adding it. And in mobile crisis, we plan to add some additional language. It's already in Appendix G, so we might just change it to refer to Appendix G. But we do allow code-mandated CSB pre-screening activities to be conducted through telehealth, which is allowed through the Code of Virginia. And that you can find that information in Appendix G to the Mental Health Services Manual. Next slide. In our remaining slides, we are going to go through a bulletin that we posted last week. It's called Telehealth Updates to Outpatient Psychiatric and Addiction Recovery and Treatment Services, which posted on April 20th. And you can see the link where you can find it there. It's where you can find all of our provider memos and bulletins. And I took a little screenshot of it last week when it was on top, just so you can see what to look for on that page. You can find it under the latest published memos and bulletins. Next slide. In the future, we're most likely going to have a separate chart in the telehealth supplement. So right now we have Table 2, which is our behavioral health services allowed through telemedicine. And I believe we're also going to have another table, which would be our behavioral health services allowed through audio-only telehealth delivery. Right now, this screen shows you the codes that we plan to allow through audio-only telehealth. These codes are all the same ones that are listed in the bulletin that we posted. And we're going to go through their names on the next slides. We just wanted to give you a slide that had all of them all in one place. For codes that are listed on this slide, providers should refer to the CPT manual for guidance on conditions that must be met to bill these codes and who can bill them. So all these codes listed on this slide, providers have to be enrolled as an outpatient psychiatric or arts provider. And some of these codes, all these codes are limited to licensed or licensed eligible professionals, like the LMHPR, RPs, and Ss. And some of these codes are limited to physicians or nurse practitioners, physician assistants, and then some of these codes are also just limited to psychologists. So you have to go to the CPT manual to figure out who can bill these codes and under what conditions. Next slide. We're just going to briefly go through the names of the codes. 90785 is an interactive complexity add-on, so it's used with another CPT code. 90791 and 90792 are the psychiatric diagnostic evaluation codes with or without medical services. 90832 and 90833 is psychotherapy for 30 minutes with or without evaluation and management. Next slide. 90834 through 90838 continues psychotherapy depending on the duration of the service and whether it was provided with evaluation and management or not. 90839 and 90840 are our psychotherapy for crisis codes. And 90845 is psychoanalysis. Next slide. 90846 and 90847 is family psychotherapy with or without the patient present. 90853 is group psychotherapy. 96116 and 96121 are neurobehavioral status exam codes. Next slide. 96127 is brief behavioral assessment. 96156 through 96159 are health behavior assessment and intervention codes. Slide. 96160 and 96161 is the administration of a health risk assessment instrument, depending on whether it's patient-focused or caregiver-focused for the benefit of the patient. 96406 and 96407 are smoking and tobacco use cessation counseling codes. I believe there's one last slide. It's 99408 and 99409 are alcohol and or substance abuse structured screening and brief intervention service codes. I believe that's the end of our slides. Oh, no, I'm sorry. There's more information. This is the additional information that's located in the bulletin that we just put out. The billing for the outpatient CPT codes. The telehealth services supplement will be updated to include audio-only telehealth policy. Until this update is in place, providers can continue to bill for audio-only telehealth for those outpatient CPT codes that were included in the April 20th, 2023 Medicaid Bulletin, as they normally would if the service was provided in person until otherwise notified. Next slide. Until the telehealth services supplement is updated, providers must follow the conditions for telehealth reimbursement outlined in the reimbursable telehealth services section of the telehealth services supplement, which is currently on page 3, and it's pretty extensive, so we would encourage you to go and look at that list. We hit some of those earlier in the presentation. Until the telehealth services supplement is updated, provider and documentation requirements remain the same as if the service was provided in person. Next slide. Oh, that was the list. So now, are there questions that, have you gathered some that you want to go through?
There are quite a few questions. I just want to say that some of them are general telehealth questions that can be answered by finding information in the telehealth supplement. So please read that, and if you still have questions, you can certainly reach out to us. So let me quickly look at the questions. There are a lot of questions, and I feel like this is potentially in the telehealth supplement too, but there are a lot of questions about, are we allowed to still accept verbal consent for signatures?
Yeah, for that, we should refer providers to the telehealth supplement.
Page 9 of the telehealth supplement. I put that in the
Whatever
chat.
the telehealth supplement says is what the policy is. And that's something that, once again, we don't have oversight over. So if you go through the telehealth supplement and you still have questions about the consent, I believe on the very next slide or very last slide, we have the email address. There it is, the VA Telemedicine at dmas.virginia.gov. That's where you would send those questions.
Sorry, I'm still reading.
I can.
So there, and I don't know that we know the answer to this, but maybe we do, Sue. So again, some of these questions we're probably going to need to take back, and we may not want to say definitively on the call what the answer is. But the question is for outpatient therapy services 90791, 90837, 90834, and a couple other ones. Must a provider see a patient in person prior to providing telehealth services?
I know the CPT manual does give some guidance on that. So I would encourage providers to go and look in start with the CPT manual and see. I know it gives guidance on, we made sure that all of these codes were allowed allowed by the CPT manual to be provided audio only. So I would encourage providers to start there.
Sue, can you speak to, I just want to, there are a couple of questions about codes that weren't mentioned today, in terms of are they going to be allowed or not? Can we speak to where we are in policy development, in terms of deciding on further codes? And yeah, can we speak to that in terms of where we are and what our next steps are?
Well, I would say the ones we provided today were the ones that when we met with our office of the chief medical officer, when we met with those staff members, these were codes that we thought we could easily allow in the interim until we had time to further develop the audio-only telehealth policy. So these codes were ones that Medicare, we looked through the list of codes that Medicare is allowing through audio-only telehealth, because we learned our lessons from the beginning of the PHE, and then when Medicare covers codes that we don't cover, then sometimes that will cause a lot of problems with claims. So we learned our lesson there. So we did go through the list of Medicare covered codes. And then as far as future codes, we will continue to work with the Office of the Chief Medical Officer to kind of go through those codes but ultimately those decisions I think will be made at that level. These were the codes that we just thought we could easily cover and be consistent with Medicare.
Okay. Thank you, Sue.
And as far as their timeline, I know that the reason we haven't been able to update the telehealth supplement is because there was a prior update that has already been posted but hasn't been finalized. So they're working on a different telehealth issue and trying to get that finalized, and then before they turn their attention back to the audio-only telehealth. So a lot of that's just kind of out of our hands.
Sue, correct me if I'm wrong here, because that's basically your main job. These codes, the codes that we mentioned in terms of now allowing them to be audio only, they are already allowed via telemedicine, which is audio and visual, and they have been allowed. This update is to say that we are now going to be allowing them, in addition to via telemedicine, which is simultaneous audio and visual, we are now also going to be allowing them to be provided audio only when appropriate.
Right. And all of these codes during the PHE were allowed audio only because we waived the face-to-face requirements for outpatient. Like Ashley would have to talk about if there were any arts ones, because those were not included in the reference that we referred to earlier, the chart that included the one that's dated April 3rd that includes flexibilities that were expiring. So if there are any arts ones that Ashley wants to speak about, but they were all allowed. Otherwise, they were all allowed through audio only telehealth during the PHE. And what the bulletin we posted last week will allow is for those particular codes to continue being allowed through audio only telehealth until we can get the audio only telehealth policy in place. The bulletin will allow you to continue those codes until you get further guidance.
There are a lot of questions about, and I think I addressed this before, but maybe I didn't. There are a lot of questions about codes that we did not talk about today. And I really encourage all providers to go and read the telehealth supplement, which identifies, all the services and the corresponding procedure codes that we allow via telemedicine and telehealth. And so if you have questions about a specific code, that's where you need to find that information. If the code isn't there, then that means it's not allowed via telehealth or telemedicine.
I see somebody just popped up on my screen is mentioning that the telehealth service supplement is dated October 2022. We need to go back and look because at one point, somehow when the telehealth services supplement got updated, it didn't get updated to all manuals. So that's something I'll add to my list is to make sure that they're all showing, unless somebody wants to quickly do it now, that they're all showing the same date. And off the top of my head, I can't remember if I believe the October 2022 one is the current one. There was a March 2022 that was still showing in one of the manuals, but not the others. And I believe that has been updated, but we should go and check.
Are you talking about the telehealth supplement?
Yes. Mm-hmm.
It is dated October 3rd, 2022.
Okay.
That's the link that's to the mental health services telehealth supplement.
Okay. And we just got that updated last month because prior to last month, the March 2022 was still showing. In the mental health manual, it was showing as the March version.
Mental health services and arts are showing the October.
Okay, good.
All right, I think the rest of the questions that were submitted, we're going to take back. We appreciate the questions, and we'll be developing an FAQ over the next couple of weeks to post to our website. The recording of this training as well as the PowerPoint will be posted to the Behavioral Health DMAS website, and there is a link to our training and resources page, and that's where it will be posted hopefully in the next week, and then the FAQ will come after that and be posted on the same page. So thank you guys for all your questions. We're definitely going to take them back, work through them. As you all know, these things are complex, and we want to give you the most accurate information we possibly can. So please keep the questions coming. You can always submit them, any behavioral health specific questions, to our enhanced BH at dmas.virginia.gov. Our team, shout out to them, is amazing. They get hundreds of questions a day, and they are absolutely amazing at getting back to everyone and tracking all those questions. I really appreciate our team getting the work done. So thank you all. And I thank everybody else for being here today. We had upwards of 500 individuals on the call today, so that is amazing. And you guys know where to reach out to us if you need us. And we look forward to seeing you at our next training, whatever that may be. Thank you, Sue, for presenting. We appreciate you. Thank you all.